Yeah, thank you and good afternoon to all. Thank you, organization, for providing me the opportunity to present this abstract. I will be talking about the lutetium PSMA-617 therapy in metastatic prostate cancer based on the two trial PSMAfore and ENZA-P trial. Right now, if we go by the algorithm, in case of metastatic castration-resistant, we have the plethora of choices ranging from abiraterone, ENZA, docetaxel, cabazitaxel, multiple, and the lutetium come at the end of treatment. Right now, I am getting the patient मेडिकल oncologist रेफर हमारे पास कुछ नहीं बचा अब न्यूक्लियर मेडिसिन में जाके देख लीजिए अगर वो कुछ कर सके तो but the vision trial had changed that thing and then lutetium is now a standard care of therapy for the patient with metastatic prostate cancer in castration resistant setting. Right now, as I said, this is the diagram that describes lutetium is sitting at the end of at a backbencher. But with the help of these two trials, whether it's PSMAfore or ENZA-P, we are trying to move forward. And whether these trials are able to justify the early course of institutional lutetium in case of metastatic disease or not, let's see. The first and foremost is the PSMAfore trial. It's a phase 3 trial that done in the taxane-naive patient with metastatic castration-resistant that has been conducted by Oliver Sato et al. In the US-based hospital. So as we know, lutetium PSMA is a targeted radioligand therapy for the PSMA positive metastatic cancer. And these are the target receptor. Can we have the pointer? Pointer there? No. So that the targeted therapy and the lutetium PSMA vision trial has shown that so the vision trial has shown that lutetium PSMA prolong your radiological progression-free survival as well the overall survival in case of metastatic cancer. The PSMAfore trial is subsequently examined to conduct whether it is helpful in case of taxane-naive patient or not. The vision was conducted in patient with the taxane-resistant patients. So this is the schema trial. Eligible patient were the PSMA positive who has at least one PSMA positive disease which are progressing on the at least one prior ARPI. And the candidate was eligible for change in the ARPI and the candidate were not eligible for the PARP inhibitor. So two arm divided randomized into 1:1. One arm received the lutetium PSMA trial with 200 millicurie at an interval of 6 weeks for a duration of 6 cycles. And the second arm received the ARPI change. That the standard care of treatment after failure of one ARPI in case of US. And then the crossover was allowed if because patient get progress on the ARPI change, he is ultimately eligible for the PSMA therapy. And later on follow-up was done. 585 patients were screened, out of which 547 underwent the gallium PSMA PET-CT, 234 were randomized into the PSMA lutetium arm, and the 234 were randomized into the ARPI change. 97 were treated with the lutetium, while in case of ARPI, 230 patients. Discontinued progression was only observed in 21.8% patient in the lutetium arm, while it was observed at the 62% in case of ARPI change. And these out of 146 patients, 123 were later on subjected to the lutetium therapy due to the disease progression. Now coming to the event-free survival, these are the Kaplan-Meier survival. You see the blue arms clearly favorable to the lutetium arm, and the gap is so much that you can drive a truck in between them just like a highway going on. If look for the number of events, it was 49% in case of lutetium arm, while it was around 72% in case of ARPI change. And look at the median radiological progression-free survival. It was 12.02 months instead of 5.6 months. It's almost more than the double of the what we have on the ARPI change. And if you look at this diagram, most of the things were in the favorable of the lutetium PSMA arm. And this is the response criteria. Objective response was observed in approx 50% of the patient who have received lutetium PSMA instead of only 15% in patient with the ARPI change. And look at the first graph. The complete response was observed in 21.1% of patient instead of 2.7, which was seen only in the ARPI change. And partial response is also on the 29.6%. not only the radiological progression-free survival, but about the quality of life, what about the event-free life and the pain intensity scale. All these are favorable in form of the lutetium arm. The later on, these are the cross-adjusted for the overall survival. This data is still collecting and the favorable response is there in terms of overall survival, but the statistical response is not so significant. The remarks or the conclusion provided by the author is that the high crossover, 84% of patients who have received the ARPI have ultimately going on to receive the lutetium, that in turn leads to the simultaneity of these two curves. But still overall survival data is still ongoing and we are looking forward, maybe in the next 1 year we can get the better overall survival. So concluding, PSMA prolong the radiological progression-free survival as compared to the ARPI change. The PSMA response, objective response, time to symptomatic skeletal event, and time to worsening of the health-related quality of life, and the pain also favor the lutetium arm. The specified crossover adjusted OS favored the lutetium PSMA, given that 84.2% crossover rate may have confounded the intention to treat analysis, because this study was based on the intention to treat the patient. So, and finally, we can say lutetium PSMA had manageable safety profile, well tolerated with better radiological progression-free survival in most of the patients. Now coming to the second trial, this one is the ENZA-P trial that led to the ENZA combination of enzalutamide plus lutetium PSMA. As we know, ENZA being increase the clonal expression of the. I think this no. You look at the first picture, they are the few yellow dots that are showing the metastatic disease. And then we started with the enzalutamide, and the second picture, there the number of bright spot or the yellow spot are significantly increased. That's the mechanism of action of the enzalutamide. If disease is PSMA avid, whether that PSMA is more active or whether lead to increase in the radiological progression-free survival, let's see. So this one is an open label randomized multicentric phase 2 trial conducted in 15 hospitals in Australia with intention to treat these patients. This is the scheme eligibility of the ENZA-P scheme: metastatic prostate, castration-resistant prostate cancer with progressing disease with PSA more than 5 and positive PSMA PET scan. These were patients were divided into two arms in the ratio of 1:1. One arm received the enzalutamide 160 milligram BD, and the another was the ENZA plus the lutetium PSMA, same dosimetry 200 millicurie for a duration of 4 doses at interval of 6 weeks. The objective was to calculate the progression-free survival, radiological progression-free survival, pain response, and other quality of life. This one is the screening criteria discussed, and these patients were the high-risk patients who are likely to progress on the enzalutamide, such as the high-risk factor include increased LDH level, ALP level, albumin was low, less than 3 years than the initial diagnosis, and more than 5 bone metastasis, along with the visceral metastasis. That's a high point, that the patient with visceral metastasis significantly have lower progression-free survival. So this was the scheme dosimetry entire. Initially, the patient go the baseline PSMA PET scan, started with the enzalutamide, then increase the expression. The second picture show the increased number of the red dot. Then at this point, we administer the lutetium PSMA, that lead to the 1 cycle, then the fourth picture with the second cycle of lutetium. And then at day 92, the PSMA PET scan was done to look for whether how is the response. If there is a complete response, no active disease is there, though no further lutetium was given and patient was followed. If some residual disease layer, patient was subjected to all the third and fourth. That is the adaptive dosimetry of the lutetium PSMA. So if we see that the beauty of the nuclear medicine, or that you detect disease, you see disease, you quantify disease, and then you treat the disease with that lutetium PSMA. Unfortunately, this patient was the progress, some residual disease after 2 cycles, so he further underwent the third and fourth cycle, and later on leads to the complete remission. These patients were followed up until the disease progression, and progression was defined as well the radiological criteria with PSMA PET or FDG PET or the prostate cancer working group. So result: 220 patients screened, 160 patient randomized, 79 received ENZA, 83 received ENZA plus lutetium PSMA. Interim analysis: at the interim analysis protocol, treatment is ongoing in 48 patients, with 16 patients still on ENZA, while 32 patients are on ENZA plus lutetium PSMA. Median follow-up is the 20 minutes. And look at the progression-free survival. In case of both the PSA progression-free as well as the radiological progression, the lutetium was significantly favored as compared to the ENZA alone. If we go for the numerical value, in case of PSMA arm, the median progression-free survival is 13 months instead of 7.8 months that was only in the ENZA only arm. And if go for the radiological progression-free survival, it was 16 months as compared to the 12 months. And look at the PSMA response. You feel that PSA level goes 50% happy for the patient happy, but you feel more happy than PSA drop to the 90%. Look at the two charts. First, the 50% response rate. In case of lutetium, it was 93% versus 68%. And 90% response rate is the 78% as compared to the 30%. That is the extent of the lutetium therapy that caused a drop in the PSA level. So conclusion, it's a first randomized trial that combining the ARCI with lutetium PSMA. There's a strong evidence of enhanced anti-cancer activity on primary endpoint with median progression-free survival of 13 versus 7.8 with significant p-value. This will lead to active life-prolonging treatment for the control group. It's a first trial that depends on the adaptive dosing, that whether you require 2 cycles or 4 cycles, that can be in between decided depending on your disease status. Planned follow-up of progression-free survival and overall survival as expected by July 2024. And along with that, we are doing the biomarker analysis. And that's the summary of the ENZA-P trial, entire recently published in the Lancet only 1 week back. And that's all from my side. Thank you.